Hi everyone, welcome to researchmd.com. Great presentation today. We're going to teach you everything about primary dysmenorrhea today, my friends. And remember, all our presentations are like under 9 minutes with all the precise facts you need. The reason for that is like we want you to review again and again. Studies have shown that more you review a subject, it kind of stays in our memory. What's the point in watching another 60-minute long presentation? You don't have time to review, okay? So just going to go a little bit faster, so please stay with us. Great presentation. Again, Pramil, Cheriyath, the program director, internal medicine residency, transitional residency, and I am a director of research, teach medical students and residents on a regular basis. I'm also assistant professor of medicine to major medical schools. So let's get into our topic. So what's the definition of primary dysmenorrhea? When you talk about dysmenorrhea, let's talk about that, right? That's like you got painful, recurrent lower abdominal cramps occurs with menstruation, okay? So there's two types, primary and secondary. So when you talk about primary, there's no pelvic pathology associated with it, that's it. When you talk about secondary dysmenorrhea, there is a pelvic pathology associated with it, like endometriosis, adenomyosis, or uterine fibroids and all that, okay? Remember the definition between primary and the secondary. When you talk about primary, there's no pelvic pathology. But when you talk about secondary, there is a pelvic pathology and the menstrual pain, okay? So epidemiology kind of just let you know, onset typically 6 to 12 months after menarche, peak prevalence during in the early 20s. Secondary dysmenorrhea usually affects women greater than 24 years old with no history of dysmenorrhea. Prevalence can from 16.8 to 90%. Estimated 10% of young adults and adolescents dysmenorrhea and reported to have secondary dysmenorrhea. So it's a big problem, the bottom line, right? So risk factors associated with it: dysmenorrhea, irregular menstrual cycles, low body BMI, tubal sterilization, and family history of endometriosis. Risk factors for severe dysmenorrhea include menarche less than 12 years old, increased duration amount of menstrual flow, smoking, and passive smoke exposure, okay? Now, etiology, again, primary dysmenorrhea caused by myometrial activity that results in the uterine contractions and manifests as painful cramps. Remember that. So we just are only talking about primary dysmenorrhea. There is like increased myometrial activity. So uterine contraction, spasm, and that kind of manifests as a painful cramp. So let's look at the pathogenesis. Okay, after ovulation, what happens? You got high omega-6 fatty acid content in the cell wall phospholipid. And after the onset of progesterone withdrawal, before the menstruation, this omega-6 fatty acid are released and they're the one who kind of trigger the uterine contraction. They use mainly like two distinct pathways, which is given right here, cyclooxygenase pathway and lipoxygenase pathway, okay? And the phospholipids are like enzymatically converted to produce leukotrienes A, B, Z, which induce uterine muscle contraction. And this lipoxygenase pathway would not respond to treatment with the COX inhibitors such as NSAID. So you need to know which type of pathway is having over here. Intensity of cramping and dysmenorrhea associated symptoms appear to be directly proportional to the amount of the prostaglandin F2 alpha released, okay? So, in comparison of the contractions, like in a normal menstruating women, and you just look at the women with the primary dysmenorrhea, uterine basal tone is minimal, less than 10, other one is greater than 10. 3 to 4 contractions each 10-minute interval, the other one have 4 to 5 contractions, okay? Active pressure reaching up to 120, and synchronized and rhythmic contraction in the normal menstruating woman, and the other one is like non-rhythmic, leading to poor uterine reperfusion, oxygenation. Pain may be more severe if if more than one abnormality is present. Just remember a little bit of difference between the normal menstruating women and women with the primary dysmenorrhea. Symptoms start several hours before and up to a few hours after onset of menstrual flow. Peak symptoms usually occurs with the maximal flow, first 24 to 36 hours. And the pain can persist up to like 2 to 3 days. It can radiate to the lower back, upper thigh. It's generally similar with each menstrual period, the symptoms. Okay, how to diagnose it? Based on the clinical history and the physical examination, that's the diagnosis. There's no imaging studies or anything with it, okay? Factors associated with increased likelihood of diagnosis of primary dysmenorrhea, initial onset 6 to 12 months after menarche, age less than 30 years old, and the co-occurrence of like headache, fatigue, bloating, genitourinary symptoms like and then also acne, flashing, weakness, you have sleeplessness, depression, and irritability. Okay, and how do you treat it? Main thing is do like activity and lifestyle modification, like a low-fat vegetarian diet may decrease the number of days, green tea consumption can help, exercise may decrease the symptoms. And the other one you might want to try is like NSAID is recommended, ibuprofen, 1 to 2 doses of regimen, 200 to 600 milligram every 6 hours needed. You can use naproxen also. Oral contraceptive may help relieve symptoms of primary dysmenorrhea. It may be considered as a first-line treatment also. Okay, thank you very much for watching. We'll be back with another presentation soon. Please subscribe to our channel. Thank you.